Good day, everybody. I'm Matt Korchansky with Advize Health. I'm here today with Frank Artiaga and Mike Devine of LA Care, and we're happy to be here as part of this LinkedIn Live that Advize Health puts on every month. And this month's topic is going to be on hospice fraud. And Mike and Frank are going to be talking about their success story with how they approach hospice fraud in their plan. And I think you're going to be very impressed what their approach is, as it avoids the whole problem of medical necessity and experts testifying against each other, and goes right to the data to show how these hospices may or may not be, bilking the system for unwarranted gains. And I think you'll see that it's a simple but very effective approach that you might want to imitate. This presentation, Mike and Frank did this presentation at NHCAA in New Orleans this year to rave reviews, and I think you're going to enjoy it. And I really appreciate how they've put this approach together, because my history with the OIG and with the UPICs, we had a lot of problems with hospice care fraud cases because we looked at it from the point of view of discharging patients alive, or being beyond the 6 months, or looking at the diagnoses of the patients. And prosecutors didn't like those kind of cases. When I was with the OIG, certainly the national press didn't like them when they were saying the OIG is saying Medicare beneficiaries are living too long. So it was this type of approach that goes to the data and avoids all of those types of variables that you don't want in the case. Seems to be a very effective way to do it. So I'm going to turn it over to Frank and Mike, let them introduce themselves, and get into the presentation. Take it away, guys. Frank?
Thank you, Matt. And thank you to the Advize team for having us here today. We are happy to be here. Hello, everyone. My name is Frank Artiaga, and I'm the lead investigator at LA Care Health Plan. A little bit of background about myself. I've been conducting healthcare fraud investigations for about 10 years now. I have worked for CMS contractors Clarent and Safeguard Services, where the focus was primarily on Medicare, and then transitioned over to managed care, where the focus has been more on Medicaid. I did work for a smaller health plan in Northern California, Health Plan of San Mateo, and now I'm at LA Care, where I've been for the last 5 years. I will say there's never a dull moment at LA Care. It is the largest publicly funded health plan in the nation. So we do see a lot of cases, and we do see a lot of different types of cases. I will say we have a pretty high caseload, but we do work hard to manage that caseload and identify and prevent fraud, waste, and abuse within our network. Today, we're talking about hospice, which always seems to be a hot topic. So I'll let Mike get us started today.
Well, thanks, and hello, everybody. So 3rd grade teachers teach in school. It says, I want you to tell me what your father does. I want you to spell it, and I want you to tell me what he'd give us if he was here right now. I said, Johnny, what does your father do? He said, my father's a baker, B-A-K-E-R, and if he was here right now, he'd give us each a cookie. Great. Susie, what does your father do? He said, my father's a banker, B-A-N-K-E-R, and if he was here right now, he'd give us each a quarter. He said, Bobby, what does your father do? He said, my father's an electrician, and he works for Anthem. And L-E-C, no, try again. A-L-E, no, listen. Think about it for a minute. We'll come back. We'll give you another try. He says, Louis, what does your father do? He said, my father's a bookie, B-O-O-K-I-E, and if he works here right now, he'd give you 2 to 1, and little Anthem don't spell electrician. So listen, welcome everybody. My background, my name is Mike Devine. I'm the director for the Special Investigations Unit at LA Care. We've got a team of about 16 investigators going after healthcare fraud. And like Matt was talking about earlier, one of the problems that we've run into is that, it's hard to kind of pin things down on a healthcare fraud. And we think we found a scheme that is one that's hard and fast, and we're able to go after it. So I want to get into it. So my background, I was a federal agent. I worked for NCIS for 24 years. And everybody knows what NCIS is, right? Here's NCIS. Well, that's not the real NCIS. The real NCIS was this. This is an actual photograph. I was actually, the guy behind me, you can see in the photograph, just the corner of his head there, that's General Jim Conway. He was the commandant of the Marine Corps. I was in charge of his security detail. And we were at an event where the staff or the cast of NCIS was there. And I had talked to Cody DePablo here, Ziva from the TV show, and I said, I think I have my picture with everybody but you, because I spent a bunch of time on the set. And she said, well, let's fix this. So I took 5 minutes out from guarding the general to get my picture taken with the movie star. And being the Marine that he was, he perfectly understood that. So, but that's the real NCIS. So we're going to talk about hospice fraud. Hugely popular now in the fraud arena. Now they're saying New Yorker says there's $22 million worth of healthcare fraud based on hospice, and it's rampant throughout California. That's one of the top fraud cases we're seeing, and so we figured a way to tackle it. And what do we get for hospice fraud? So to set the stage for hospice, hospice is based on a terminal illness and a terminal injury. And basically is looking at a prognosis of 6 months or less to live. So you need a terminal diagnosis with a doctor's prognosis of 6 months or less to live. And I know sometimes when we're out interviewing these people that are enrolled in hospice, we're asking them, do you know what hospice is? And they're like, well, isn't that when you go to the hospital? And so some of these people we're interviewing on these cases, they have no idea what hospice is. They think it's when you go to the hospital. But this is what we're actually looking at when we're talking about, a hospice case. And what's the problem when you work hospice case? Matt talked a little bit about this before, right? You got Dr. Smith says that this person should be in hospice, and Dr. Jones is saying that this person shouldn't be in hospice. And now you got a battle between the medical experts, right? Now it becomes a medical necessity issue. Well, which prosecutor wants to take that case? None. You're not going to find anybody that's going to want to take that case. So it becomes a problem. One of the things we're finding is on these hospice cases is normally a hospice is approved for 6 month intervals, right? So you approve somebody for hospice care, it's end of life care. We're assuming that based on, the previous requirement earlier that they have 6 months, to live under normal circumstances. So it's approved for 6 months. Now it can get approved again. And you can get re-up for another 6 months. But as you keep going, right, we just had somebody here that got approved for the 11th time. That means they've been on hospice for 5.5 years. I submit to you, they probably should have never been on hospice in the first place, because they didn't have that prognosis that they were going to live for less than 6 months.
Hey,
The other
Mike,
thing we're finding.
one question on when someone is put on hospice care, what does that do to the rest of their benefits? Do they give those up and their benefits are now limited to the care given to them by the hospice?
Not completely. In other words, if you're on hospice care and you have an earache, you can obviously go to the doctor to get your earache treated. What you're not supposed to be doing is going to hospice care is going to the doctor to get more care for what put you on hospice care in the first place. In other words, you're not supposed to get additional chemo treatments or additional type of treatments as to what diagnosis got you on hospice in the first place. And
Thanks.
that's
And for anybody that wants to ask a question, please put it into the chat, and we'll answer that as we go along when we have a chance. Thanks, Mike.
Happy to answer questions. Sure. The other thing we're finding, and they call it churning and burning, right, is when these hospices shut down and they open up into a whole new entity. And in California, at least, they've shut that down where they're not supposed to be able to do that. But we find that where people are just saying, well, we're just going to close our case and find another hospice that may have closed and opened under that one. So, today they're XYZ hospice and tomorrow they're ABC hospice. And if they get closed down again, then they go to CDF hospice or whatever. So they just kind of change the name and go back under the same type of deal. Here's a place that we went into in Van Nuys. And this just looks like a simple, mall, strip mall place that we went into. if you drive through the entrance there, this is what the inside of that facility looks like. And this used to be an old, I don't know whether it was a Days Inn or Best Western or whatever it was, but it looks like an old hotel. And what they did is they converted each of those rooms into an office. And as we walked around, I went there with a couple of other agents, and we walked around, and each one of the rooms was set up as an office. And I think there was about 40 hospice offices in this one facility, this one address. We had cases on about 23 of the hospices located in this one facility, and actually went through and probably should have had more. But this was just a cluster of these hospices, and this is what it looked like in the offices. I mean, it wasn't set up. I mean, there's not much there. There's a Costco table and a printer and a couple of file cabinets. It's set up with a Costco desk and a chair, and here's a monitor. Where's the computer? This one here didn't even have the computer in it. So we took it and we came up with a fraud initiative, and we worked together with our data analytics people and our folks, along with our payment integrity people and our configuration people, and we took a task force approach at this. Our people, we got together with them and we discovered that there's a code. And write this down, folks. This is a winner. It's 0650. It's the revenue code 0650. And then we got our data analytics people to say, run the codes and tell me how many people are getting billed for 0650 for longer than 60 days. 0650 is home health care, home hospice care, and it's the high-end approach. And so you're only allowed to bill that for 60 days. After that, you've got to bill down to 0659. So this is a hard and fast rule. This is not, and we went to the people and I said, listen, tell me the modifier, tell me the reason, tell me the justification, tell me the excuse that you can use to bill this for longer than 60 days. And there isn't one. It's a hard and fast rule. The only way you can do that is if they change hospices. But as long as you're enrolled in the same hospice, you can only bill that code for 60 days. So we had our data analytics people run the code, and they spelled it out, right? Here's the number of people we had. And they came back to us and they said, how many people do you have? 300. Well, that's 300 cases. Well, we can't take that. So we racked them and stacked them and went from the top. Here's the code, the way it's set up, right? 0650 is the high-end code, billed for the first 60 days of routine home health care for hospice care. After that, they got to bill a 0659 for anything past the 60-day code. Now, the beauty of one of the things we did was we went, well, I'll get to that after. Here's the thing here where we went to the CMS, the regulations for what you can do and how you can bill it. And it specifically says, right, that it is here for level of care for the first 60 days of service. And that's how it's calculated. So the Advanced Analytics Lab, they identified 300 hospices wrongfully billing the home health, the revenue code 0650, longer than 60 days. We said by falsely representing that they were entitled to be paid for these services, that these hospice claims were fraudulent, that they weren't acceptable. And the total amount of wrongfully billed revenue code 0650 of those 300 hospices was about $4.8 million. So it becomes a significant case when we went after these folks. And to date, we've sent out letters for about 4.2 of the 4.8 million. The only reason we haven't gotten the other 600,000 is because we just haven't had the manpower to get to them yet. These things do take some time. And if you look at this slide here, this shows you about the amount of the validated recovery amount is the amount that we've sent for the top hospices. So you can see 588,475, more than six-figure cases on these hospices. So we've had some really good recoveries and some really significant cases that we've written on these hospices. And what do we look at in a hospice? Somebody asked me earlier about what the difference is between when you go after a hospice, what is fraud, what is the difference between fraud and abuse, and how can you go back longer than a year? And so the simple answer is fraud is an intentional deception or misrepresentation. So the difference between fraud and abuse is the intent. What did they intend to do? And our contention is that if you build this out straight up 0650 for all your patients across the board, that's a fraud. Frank, I think this one's yours.
Yes. So I'll continue with our action plan. So now that we had the list of hospices to go after, we had to come up with an action plan. And the first step in that action plan was putting together that recovery letter. And one of our senior investigators took the lead on that, and he did a fantastic job at drafting that very first recovery letter. The letter was extremely detailed. It cited the rules and regulations, provided clear examples of claims identified that were wrongfully billed, and the step-by-step process on how the overpayment was calculated. The letter was created so that it could be used for all hospices identified in this project. All you really had to do was just change the hospice information and the claim examples. The next step in our action plan was the training. The same senior investigator who drafted the overpayment letter got us all together. We went over the letter and how to verify and calculate the overpayment. And once the entire team felt comfortable with that, then the cases were assigned. The final step, which was the most time consuming in this process, was the manual review of the hospice data to calculate the overpayment. So our analytics team, they were only able to provide us with an estimated figure for these overpayment calculations for each of these hospices. And by the time all these cases were assigned, there was a bit of a time lapse. So once these cases were assigned to the investigator, what we had to do was rerun the data so that we can get the most up-to-date claims information. And then we manually reviewed the data so that we can validate the overpayment amount. So once all that was completed, we were able to mail out our overpayment letters. As mentioned in the previous slide, the most time-consuming part of this project was that manual calculation of the overpayment. Essentially, what we had to do was first verify whether revenue code 650 was paid for more than 60 days. Any claims paid over the 60 days, we then identified the amount LA Care incorrectly paid, and then we calculated what LA Care should have paid if the correct revenue code was billed. So the difference between those two amounts was the overpayment for that particular member's hospice claims for that particular case. Again, we have to consider the correct payment amounts depending on the fiscal year services were rendered, as hospice rates, they do change every fiscal year. Next slide. And there you go. Here's an example of the rates that they change. So we have 2020, 21, 22, 23 up there. And they don't change by very much, but there's a slight change, which will definitely result in a slightly different overpayment amount.
So the results. Oh, go ahead.
Go ahead.
Well, so the results on these hospice providers, most of them have agreed to pay us back on what we had for the letters. We actually have had really good success, even with non-par providers, non-contracted providers. So that was good. We've also taken a change of behavior, right? We've stopped this going forward. And what we did is we notified the configuration team, and they were able to put an edit in the system. One of the things we did is, it doesn't do any good to keep trying to pick off these hospices if the bleeding stops. So we were able to stop the bleeding. And one of the things we did is our configuration team was able to put an edit in the system so that the system itself won't pay past 60 days on the 0650. It automatically drops it down and pays the 0659, which is the way it should be done. So we've run our overpayments of 0650 effectively down to zero, practically zero, where we're not having that as a problem anymore. Really important to do. One, to go after them with the letters to get the recoveries, but two, to stop the bleeding with an edit in the system. So that was good. One of the problems that we've had, right, is lawyers always came, and I talked about this before, and they always in California, they cite the Knox-Keene Act, right? That says the SIU can only go back 365 days. And, you know, my response to that is, no, that's laughable. And Frank and I, in fact, we were on a case and we were talking to a lawyer. And the lawyer says, first, he says, you know, it's really your fault. You paid the claims. And I asked the lawyer, have you been doing this very long? Because let me give you a hot tip. That's a loser. That's not going anywhere. That's not going to get you nothing. That's done. Then the second one was, well, we have to do this, you know, because, you know, you can't go back more than 365 days on these claims. And I said, so tell me this, why is it that you lawyers always, when you cite Knox-Keene, cite the first two sentences of the paragraph, but you never cite the third one? And what does the third paragraph, the third line say? And he started laughing because he knew I was right. It says that the 365-day time limit shall not apply if the overpayment was caused in part or in whole by a fraud or misrepresentation by the provider. And again, we're saying that it's a fraud. They're going back more than 365 more. They're billing the 0650 longer than 60 days. And we haven't had any problems with this so far. Question.
Hey, Mike.
Oh, go ahead.
Hey, Mike, sorry to interrupt you, but just really quick, when we go back to slide 12, I just want to bring up these codes again, because we had an instance where we were discussing the same situation, and there was an individual who didn't understand the codes or maybe missed this part. But I just want to discuss this again one more time, that we're only looking at these two codes, and this made it really easy. We only have to look at two different codes. So we have the high rate revenue code 650, which could only be billed for the first 60 days of routine home care and a patient certification period. And then you have the lower rate, which is 659, and that can be that's billed beyond the 60-day period. So again, just want to bring that up. We're only looking at two codes. These are revenue codes, not CPT codes. So please keep that in mind. And then another thing I do want to bring up on slide 13, the next slide. Yeah, if you do want to look up this information, or you want to dig into these rules and regulations, you can always look at the Medicare Claims Processing Manual, Chapter 11. But a few things I do want to bring up that are extremely important. The first thing is that, Medicare counts. So when billing revenue code 650, Medicare counts 60 days from the date of admission, regardless of whether some days are covered or non-covered. The second key point that I do want to bring up is that the 60 days are counted on a beneficiary level across any hospice benefit periods that are not separated by a 60-day gap. So what does that mean? So let's say you have hospice A, they discharge a patient, and then that same patient gets readmitted to hospice A. If there's no 60-day gap there, then hospice A, they cannot restart the billing of revenue code 650. And the same is true if we have hospice A and we have the patient gets discharged from hospice A but goes to hospice B. If there's no 60-day gap there, then hospice B, they cannot restart, or they should not restart the billing of revenue code 650. So those are some key points I wanted to make sure we're clear.
All right, thanks, Frank.
Yeah, thank you both. I have just one follow-up question. You made some great points about the importance of coordinating and collaborating with the other arms, with the UM and with the data team to really make this thing work. What was the germ of this? What was the reason you started looking at this particular issue? How did it come to your attention?
We've been working, we've been getting a lot of complaints on hospice and people enrolled in hospice. And we actually formed a group at LA Care and to sort of take a task force approach at looking at hospice fraud. And so we meet with and data analytics people every single week to go over stuff. And I can't remember which department came up with the idea, but when we started looking at this, it morphed into the great big huge. It became one of our lead projects. So tremendous support from and tremendous support from our data analytics people. And then when we're sending out these letters, we work hand in hand with payment integrity every day at LA Care. And they're correcting the claims on all these money when it's coming in. And like I said, and then we worked with with configuration to shut the bleeding off. So not only are we sending out letters to get recoveries, but we're stopping it from happening in the future, which is a big thing. And the prevention aspect of it is a big thing in LA Care. So that's really important for us. I will say
to emphasize that enough. That's very important. You worked collaboratively to find it, to develop it, and then also to stop it in the future. And that's the real role of an SIU, is to work with those other teams to identify the problems, solve them immediately, and then also solve them in the future. That's a tremendous way to do it. And you found an effective way to do it that was, probably resource intensive, but considering you didn't have to do medical reviews on any of these or anything like that, I'm sure these things were a lot simpler than the usual cases that you would deal with on by an SIU. So kudos to you guys for doing this. It's an amazing job.
Well, thanks, Matt. And listen, if anybody out there, would like to see a sanitized copy of our letters, how we were going after them, what we were using for justifications. We talked in the PowerPoint about the sites and where to go for that. But we're happy to share. We're happy to help anybody get this thing, a project up and running. I know we've had other plans in California. We've done this briefing before, and we've had other plans come in and go after people for the 650, and they've had great success. So, we're happy to share the wealth and get this thing rolling. And I think it's great when we can get we can sanction these fraudulent providers on hospice fraud. So
great. Thank you so much. Thank you, Mike. Thank you, Frank. And for the audience out there, again, this is a LinkedIn Live. Advize Health has these every month. Please tune into those. Tune into our OIG Roundtable. Look into getting our newsletter that we put out every Friday that includes links to these as well, and provides some news updates and things of that about Advize and about our views and perspectives on the healthcare industry. And we try the best to provide as much information as we can, and having guests like Mike and Frank here is just an example of that. So thank you all very much, and we'll be seeing you later.